Welcome to the Hospital Medicine Unplugged podcast.
Today we are dissecting a clinical entity that every single one of us, whether you are a hospitalist, an intensivist, or holding down the fort in the emergency department, has managed.
Absolutely. It's a pathology that feels so familiar, almost routine even. We're talking about anaphylaxis.
But, and this is important, if you're listening to this expecting just a review of hives and Benadryl, you are probably in the wrong place.
Right.
Our mission for this deep dive is to really strip away the comfort of that textbook presentation. We want to focus entirely on the nuance of recognition.
We're looking for the cases that keep us up at night, the treacherous presentations that lack cutaneous manifestations, the so-called silent killers.
And we're going to break down the management of refractory shock. What do you do when your standard epinephrine dosing is failing?
It's a critical question. And to answer it, we're going to be synthesizing a pretty massive stack of sources.
We've pulled data directly from the World Allergy Organization 2020 guidelines, the seminal NIA DVAN diagnostic criteria, and a lot of the most recent literature on pathophysiology and biphasic reactions.
So we're sticking strictly to the evidence here. And to start, I think we really need to frame the stakes correctly, because it's easy to look at the epidemiology and get complacent.
That is the dangerous trap.
Yeah.
It really is. When we look at the mortality data, it just underscores the urgency of this discussion. Case fatality rates in hospitalized patients for anaphylaxis hover roughly between 0.25% and 0.33%.
And when you just hear that number, it sounds small, a fraction of a percent.
It does, but we have to translate that into clinical reality. What does that actually mean?
Exactly. To a clinician, 0.33% is not a statistic. It's a preventable death. It is a young person who walked into a restaurant or took an antibiotic and didn't walk out.
Every single one of those deaths represents a catastrophic failure in the chain of survival. And usually that failure isn't because we didn't have the right drug.
No, it's because we didn't recognize the syndrome in time.
The primary driver of survival is not some novel therapeutic agent or a complex ICU intervention. It's immediate identification and administration of epinephrine. Time is absolutely the enemy here.
So let's establish exactly what it is we're treating. The clinical definition is, a severe, acute, life-threatening, systemic allergic reaction.
But even that phrase, allergic reaction, sounds a little too benign for what's happening.
It does. We need to focus on the term anaphylactic shock.
This is a circulatory collapse.
Yeah?
It's characterized by distributive shock, and we need to visualize what is actually happening in the vasculature at that moment.
You have systemic vasodilation. I mean, the bottom completely falls out of your vascular tone.
Right, and at the same time, you have this drastically increased permeability. The endothelial barrier just fails.
So you've got relative hypovolemia. You might have 5 liters of blood in your body, but if your tank, the vasculature suddenly doubles in size and half the fluid leaks out into the tissue.
Your effective circulating volume is critically low. The heart is pumping against nothing.
So let's talk about the epidemiology. The incidence is significant, and it seems to be rising.
It is. We're looking at numbers like 50 to 112 episodes per 100,000 person years. And the lifetime prevalence in the U.S. is anywhere from 1.6% to as high as 5.1% of adults.
And there's a really distinct demographic shift that is crucial for our history taking.
Mm-hmm. If you're admitting a toddler, let's say, the trigger is almost certainly going to be food. In children aged 0 to 4 years, food triggers are the predominant cause, no question.
But the picture flips completely as the patient ages.
It does. Once you look at adults over the age of 50, medication-induced anaphylaxis becomes the primary driver. This is a vital heuristic for any hospitalist.
Absolutely. If your elderly patient crashes on the ward, don't look at their lunch tray first.
Look at their MAR. Look at their medication list.
That really tracks with the hospitalization trends we're seeing. Hospitalization rates increased significantly between 1999 and 2009.
But interestingly, the case fatality rates among those who are hospitalized have actually decreased.
So what does that paradox tell us?
Well, it suggests that perhaps our in-hospital management is improving, which is great. Or maybe we just have lower thresholds for admission now, so we're capturing less severe cases.
But we can't let that lower fatality rate lull us into a false sense of security.
Never. The physiology of a lethal reaction is always lurking under the surface.
Okay, so let's get into that physiology. We often simplify this to just histamine release, which I think we can agree is a gross oversimplification.
It is. We have to look beyond histamine if we want to understand refractory shock. We need to unpack what's been called the cytokine storm of allergy.
So where do we start? the classical pathway.
Let's start there. The IgE-mediated mechanism. This is what most of us learned about.
So in this scenario, you have a sensitization phase. The patient is exposed to an allergen for the first time, say a peanut protein or beta-lactam.
And their B lymphocytes produce specific IgE antibodies. These antibodies don't just float around freely. They bind to these high-affinity Xe-epsilon-RI receptors on the surface of mast cells and basophils.
So the patient is now essentially a loaded gun.
They're primed. Exactly. Then comes the effector phase. Upon re-exposure, the allergen cross-links those IgE receptor complexes.
And that physical cross-linking triggers an intracellular cascade.
That leads to degranulation. The cell just dumps its contents.
But here's where it gets fascinating and honestly a bit terrifying for us as clinicians. We have these non-IgE mediated mechanisms.
This is so critical because clinically, these presentations look identical to IgE-mediated anaphylaxis. But you have pathways that completely bypass IgE.
Not quite.
We're talking about IgE-mediated reactions, complement activation, contact system activation, and even direct mast cell activation via something called MRGPRX2 receptors.
Let's pause on that one. MRGPRX2 receptors. This explains so much. This is why certain drugs, like fluoroquinolones or vancomycin, can cause anaphylactoid reactions on the very first exposure.
Exactly. There's no sensitization phase needed for those. The drug molecule itself directly triggers the receptor.
The mast cell doesn't care how it's activated.
It doesn't care. Whether it's IgE, cross-linking, or direct stimulation of that receptor, the end result is the same. The explosive release of mediators. And the treatment remains exactly the same.
Right. You do not wait to figure out the mechanism before you give the epinephrine.
Absolutely not. You treat the syndrome.
So let's talk about what's actually released in this cytokine storm.
You can think of it in two ways. First, you have the preformed mediators. These are already packaged in granules, ready to go. They're released immediately within seconds.
And this includes?
This is your histamine, heparin, tryptase, and chymase. This is the initial punch.
And then there's a second wave.
Yes, the de novo synthesis. After degranulating, the mast cell starts manufacturing a whole new set of weapons. Lipid mediators like cysteinoleucotrienes, prostaglandins, and platelet activating factor, or PAF.
And cytokines.
And cytokines like IL-4 and IL-6. It's a sustained secondary assault.
I want to focus on the mechanism of shock here, because this really dictates our entire resuscitation strategy.
It does. Histamine and PAF, which we just mentioned, they activate nitric oxide production in the endothelium.
And nitric oxide is a profoundly potent vasodilator. It relaxes the smooth muscle of the vessel wall.
So you get this massive systemic vasodilation, but that's only half the problem. Simultaneously, you're getting endothelial barrier dysfunction.
I like to think of the blood vessel as a pipe made of bricks, the endothelial cells. And normally the mortar betwixt those bricks, the adherence junctions, is really tight. Nothing leaks out.
That's a great analogy. But these mediators, they cause the endothelial cells to literally contract, pulling apart those adherence junctions. The mortar basically dissolves.
So the pipe becomes a mesh screen.
Precisely. You get massive fluid extravasation. You're shifting volume from the intravascular space directly into the extravascular space.
Which explains why these patients can be so profoundly volume depleted despite having no external fluid loss. They're third spacing their entire blood volume into their own tissues.
Correct. And that brings us to the real diagnostic challenge. Because this physiological storm is happening internally, we often have to rely on external signs to diagnose it.
But the diagnosis is purely clinical. We do not have a point-of-care lab test that says anaphylaxis.
We don't. We have to rely on the NIH-FAN framework.
Right.
And I think a lot of us learned these criteria for boards and then maybe forgot some of the nuance.
Well, let's go through them. The framework is designed to be sensitive, right? To catch patients before they arrest.
Exactly. So criterion 1 is acute onset. This involves the skin, or mucosa, hives, pruritus, flushing, swollen lips, and D. At least one other system.
That ND is the key word, so skin plus respiratory compromise.
Right. Or skin plus hypotension and end organ dysfunction.
Or skin plus persistent gastrointestinal symptoms.
Right. So if you have hives and you're wheezing, that's anaphylaxis. If you have swollen lips and you pass out, that's anaphylaxis. That's the one we all recognize.
But criterion 2 is where it gets tricky. This is where I think we see misdiagnoses. Skin involvement is not strictly required if you have a likely allergen.
This is so important. Criterion 2 is 2 or more systems involved rapidly after exposure to a likely allergen. The systems are the same: skin mucosa, respiratory, reduced blood pressure, or persistent GI symptoms.
So let's paint a picture. A patient eats a peanut. 5 minutes later, they start vomiting profusely and they start wheezing. But there are no hives, no flushing.
That is anaphylaxis. The vomiting is the GI system. The wheezing is the respiratory system. That meets the criteria. If you wait for the rash to show up, you are delaying life-saving treatment.
And then we have criterion 3. This is the shock presentation, the one that scares us the most.
Criterion 3 is reduced blood pressure alone after exposure to a known allergen. Just that.
And for adults, how do we define that reduced blood pressure?
The systolic blood pressure, less than 90 millimeters of mercury, or a decrease of greater than 30% from their baseline.
So consider a patient with a known severe bee sting allergy. They get stung, they collapse, their pressure is 80/40, but they have no rash, they have no wheeze.
That is anaphylaxis. You do not wait for another symptom. This is the silent killer presentation.
And there's a statistic on this that's really sobering.
It is. In fatal anaphylaxis cases, cutaneous symptoms are absent in up to 20% of patients.
1 in 5.
1 in 5.
Yeah.
The shock happens so fast that the vasculature collapses before the skin even has a chance to manifest the hives.
That is a chilling stat. It completely challenges the heuristic that anaphylaxis equals hives.
It forces us to broaden our differential for any unexplained shock.
Yeah, we often hear about tryptase. Residents love to order it. But what is the actual utility of serum tryptase in the acute setting?
In the heat of the moment, absolutely zero.
It's a retrospective tool.
That's all it is. Ideally, you obtain a serum tryptase level about 90 minutes to 4 hours post-event. The diagnostic threshold is an increase of at least 1.2 times the baseline, plus 2 nanograms per milliliter.
But we have to emphasize the massive caveat here.
A huge caveat. Normal tryptase levels do not rule out anaphylaxis. It is not a perfectly sensitive test.
So it's useful for confirmation later, maybe to differentiate it from a panic attack or a cardiac event.
Or scombroid poisoning, sure. But you never ever delay treatment waiting for a lab draw. If you are thinking about ordering a tryptase while the patient is hypotensive, your priorities are wrong. You are prioritizing paperwork over physiology.
Let's shift gears to triggers and cofactors. When we talk about foods, the big 9 account for over 90% of Ig-mediated food allergies.
Right. And for everyone listening, that list is crustacean shellfish, dairy, peanut, tree nuts, finfish, egg, wheat, soy, and now sesame.
And among all of those, peanut really stands out.
It does. Peanut is the leading cause of fatal food anaphylaxis. It just carries this disproportionately high risk, likely due to the potency of the allergen and the stability of the protein.
But there's an emerging entity that hospitalists, particularly those of us in the Southeast and on the East Coast, need to be really vigilant about: alpha-gal syndrome.
This is becoming so much more prevalent. It's associated with tick bites, specifically the Lone Star tick. In the southeastern U.S., the prevalence of sensitization is incredibly high. We're seeing between 20% and 31% in some areas.
And the mechanism here just breaks all the rules of a standard food allergy.
It really does. It's not a protein allergy. It's sensitization to a carbohydrate moiety called alpha-gal, which is found in mammalian meat. So beef, pork, lamb.
And the reaction is famously delayed.
This is the key. This is the midnight anaphylaxis.
Explain that.
A standard food allergy, like peanut, hits you within minutes of the meal. Alpha-gal hits you 3 to 6 hours later. So the patient eats a burger for dinner at 7 p.m., they go to bed feeling fine.
And then they wake up at 2 a.m. in full anaphylactic shock.
Exactly. And if you don't ask about what they had for dinner specifically, or if you don't ask about recent tick bites, you will miss this. You'll call it idiopathic anaphylaxis.
And you'll send them home to eat another burger.
It requires a very high index of suspicion.
Moving on to medications. We all know beta-lactams are the kings of drug allergy.
They are. But we also see significant numbers from NSAIDs, about 7% to 12%, as well as chemotherapy agents, biologics, and of course, ACE inhibitors.
We also need to discuss cofactors. I like to call these the threshold lowerers, the things that can take a mild intolerance and turn it into a life-threatening event.
This concept is so vital for patient education. A patient might tolerate a small amount of an allergen on a normal day, but if you add a cofactor, the threshold for mast-cell degranulation just drops.
And these factors include things like concurrent illness, a fever,
Alcohol consumption, menstruation, and a big one is exercise.
which brings us to food-dependent exercise-induced anaphylaxis.
This is such a specific and fascinating phenomenon. Anaphylaxis occurs only if exercise happens within about 4 to 6 hours of ingesting a specific trigger. Wheat is a common culprit here.
So the patient can eat a bowl of pasta and watch TV. They're totally fine.
Right. And they can go run a 5K on an empty stomach. Also fine.
But if they eat the pasta and then they go run the 5K,
They anaphylax. The exercise increases gut permeability and blood flow, which increases the absorption of the allergen and simultaneously lowers that mast cell threshold. It's a perfect storm.
Let's move to the most critical part of this deep dive, acute management. And I think we need to be really dogmatic here. The first-line therapy is non-negotiable.
It is epinephrine, intramuscular epinephrine in the mid-anterolateral thigh, period.
Let's be very specific about the dosing, because underdosing is an incredibly common and dangerous error.
For adults, the dose is 0.5 milligrams. For pediatrics, it's 0.01 milligrams per kilogram, up to a maximum of 0.3 milligrams. And we were using the 1.1000 row concentration, which is 1 milligram per milliliter.
And the frequency, how often are we giving this?
You repeat it every 5 to 15 minutes as symptoms persist or recur. Do not be afraid to give that second dose. Or a third.
Now, I want to address the elephant in the room. The fear. We have all stood at the bedside of a 90-year-old with a history of CAD, maybe a previous MI, who is having an allergic reaction. And there is that hesitation, that little voice that says, if I give this patient epinephrine, am I going to cause a STEMI? Am I going to cause VTAC?
That hesitation is natural, but it is incredibly dangerous. We must be crystal clear about this. There are no absolute contraindications to epinephrine in anaphylaxis. None.
You have to weigh the risks. What's the risk of giving it versus not giving it?
Think about the physiology. If you withhold epinephrine, the patient enters profound distributive shock. Their coronary perfusion pressure plummets because their diastolic pressure crashes to the floor. They will get myocardial ischemia from the hypotension alone.
So by trying to protect the heart by withholding epinephrine, you're actually dooming it to ischemia from shock.
Exactly. Uncontrolled anaphylaxis will cause cardiovascular collapse. Epinephrine restores vascular tone. It restores diastolic pressure. It saves the coronaries. You might see some tachycardia. You might see some ectopi, but you will save the patient's life.
And why the thigh? Why are we so specific about the mid-anterolateral thigh, not the deltoid?
It's all about the pharmacokinetics.
Yeah.
The studies are very clear on this. You get superior plasma concentrations when you inject into the vastus lateralis compared to subcutaneous tissue or the deltoid muscle.
It's just a massive muscle with high vascularity.
It is. It acts as a perfect depot that gets the drug into the system fast.
Okay, so epinephrine is on board. Now we can look at adjunctive therapies. And positioning matters more than people realize.
It matters immensely. We want the patient supine or in Trendelenburg if they can tolerate it.
Yeah.
We have to prevent what's called empty ventricle syndrome.
Can you explain that for us?
Sure. Remember, the patient has massive vasodilation and relative hypovolemia. Their venous return is severely compromised. If you stand them up, gravity pulls what little effective blood volume they have left in their legs. Venous return to the heart drops to near zero.
The heart is pumping air.
Effectively, yes. You get pulseless electrical activity or a systole instantly. Patients have died simply because they stood up to walk to the stretcher or tried to go to the bathroom. Keep them down.
And speaking of volume, fluids are critical. This is not a keep vein open situation.
No, this is aggressive crystalloid resuscitation. It's required because of that third spacing we discussed earlier. The bucket is leaky. You have to pour water in faster than it leaks out until the epinephrine can seal the holes.
So what are we talking volume-wise?
In adults, 1 to 2 liters rapidly, wide open. In pediatrics, 20 milliliters per kilogram boluses.
What about the second-line agents, the antihistamines and steroids? We often see these prioritized, sometimes even given before epi.
And that is a critical error. They are purely adjunctive. They are never monotherapy. H1 antihistamines like diphenhydramine and H2 antihistamines like ranitidine. They treat cutaneous symptoms. They might reduce itching and hives.
But they do not treat laryngeal obstruction and they do not treat shock.
Correct. You cannot Benadryl your way out of a closed airway or a blood pressure of 60/30.
And corticosteroids, methylprednisolone or prednisone.
Their onset of action is far too slow for acute shock. They take hours, 4 to 6 hours, to really start downregulating the inflammatory response.
So why do we give them?
We use them theoretically to prevent protracted reactions or, more famously, biphasic reactions, though the evidence for that is actually quite debated. But in the first 10 minutes of a crash, they are essentially placebo.
Right. Bronchodilators like albuterol have a role for bronchospasm, but there's a specific agent we need to mention for patients on beta blockers.
Yes. Glucagon. This is a checkmate move in a very specific scenario.
If you have a patient on beta blockers, their beta receptors are occupied.
Exactly. So you give epinephrine, which is a beta agonist, but it can't bind effectively because the beta blocker's in the way. It's like trying to open a locked door with the wrong key.
So how does glucagon help?
Glucagon has its own distinct receptor on the myocardium. It bypasses the beta receptor entirely to increase intracellular cyclic AMP. This increases inotropy and chronotropy independent of the beta adrenergic system. It's the backdoor key.
Okay, let's talk about the nightmare scenario. Refractory anaphylaxis and shock.
We generally define refractory anaphylaxis as a failure to respond to 3 or more doses of IM epinephrine. This occurs in approximately 1% of cases, but it feels a lot more common when you're the one at the bedside.
At this point, the patient is actively trying to die. We need to escalate to IV epinephrine. But this is a very high-risk intervention if it's done incorrectly.
This is a critical safety note. You cannot just push the IM solution, IV. The 1.10 solution is far too concentrated for a direct IV bolus in a heart that's still beating. You will cause a hypertensive crisis or a lethal arrhythmia.
You absolutely must dilute.
You must dilute. We dilute the commercial 1.100 solution to 1.10,000, or even 1.100,000. For a push dose pressor, we typically want 1.1 under 1,000. That's 10 micrograms per milliliter.
Let's walk through the mental math on that really quickly.
Okay, take a 10 milliml flush of normal saline, squirt out 1 ml, so you have 9 milliliters left. Take your 1.1000 cardiac epinephrine ampule, the one you use in codes. Drop 1 milliliter of that into your flush. Now you have a 10 milliliter syringe containing 100 micrograms. That's 10 micrograms per ml.
And the dosing strategy here.
If the patient is in imminent cardiorespiratory arrest, you can be more aggressive, maybe even with a 1 milligram bolus of the standard code dose epi. But if they just have refractory hypotension, but they still have a pulse, you start a continuous infusion.
And titrate to effect.
Start low, go up fast. Your goal is to maintain a mean arterial pressure of 65.
Beyond epinephrine, what advanced support options do we have?
We look at alternative vasopressors. Norepinephrine is an excellent choice. It provides potent alpha agonism to clamp down on those massively dilated vessels.
Vasopressin.
Vasopressin is also useful, especially in acidotic states where catecholamines might be less effective.
And in the most extreme cases, we can consider something like methylene blue.
This is fascinating physiology. Methylene blue inhibits nitric oxide synthase and guanylate cyclase. Remember how we said nitric oxide is the driver of that massive vasodilation?
Right.
Methylene blue effectively turns off the tap. It stops the vasodilation pathway cold.
Or, as a last resort, extracorporeal life support ECMO as a bridge to recovery.
If the heart is empty and the vessels are wide open, sometimes you just need a machine to do the work until the inflammatory storm passes.
No, let's say the patient stabilizes. We've won the battle. But we have to worry about the biphasic reaction. This is the hidden fire.
This is the recurrence of symptoms after they've completely resolved, all without any re-exposure to the allergen. You treat them, they look great, and then suddenly, hours later, they crash again.
What's the timing on this? When does it usually happen?
The median duration between the initial and the secondary reaction is about 10.5 hours. But the range is incredibly wide. It can occur up to 48, even 72 hours later in some reports.
And how common is it, really?
The historical literature cited rates as high as 20%. More recent, better quality data suggests it's likely much lower, probably less than 5%.
But clinically, we can't predict exactly who will have it, so it's a game of probability.
It is. But there are risk factors that should definitely heighten our alarm.
Such as?
A severe initial presentation is a big red flag. If they're required more than 1 dose of epinephrine to get stable, they're at higher risk. If the trigger is unknown, or if they have a personal history of previous biphasic reactions, you have to watch them like a hawk.
And this directly dictates our observation guidelines. We can't just treat these patients immediately after 1 dose of epi.
No, that is negligence. For a standard, uncomplicated case, say, some hives and mild wheezing that resolved instantly with 1 epi injection, we recommend a minimum of 4 hours of observation.
But if there was real respiratory compromise, stridor, significant wheezing,
we extend that to 6 to 8 hours.
And if there was any hypotension or shock?
That patient needs 12 to 24 hours of observation. They likely need to be admitted to the hospital. You do not want them having a biphasic reaction in the hospital parking lot.
Is there a safety metric we can use to feel more comfortable?
Well, there's data that a 1-hour symptom-free period has about a 95% negative predictive value for a biphasic reaction.
That sounds pretty good.
It sounds good, but 95% means that 1 in 20 patients will still react. And given that the consequence could be death, the guidelines strongly recommend those longer observation windows for safety.
We touched on beta blockers earlier with glucagon, but let's do a special consideration section just for ACE inhibitors and beta blockers. These drugs are ubiquitous in our patient population.
They are, and they fundamentally alter the patient's response to anaphylaxis. It really comes down to the pathophysiology of risk.
For beta blockers, they limit the compensatory tachycardia.
Exactly. When a patient vasodilates, the body's natural reflex is to rev up the heart rate to maintain cardiac output. Beta blockers blunt that reflex. The patient can't mount the tachycardia they need to survive the shock.
And ACE inhibitors, what's the mechanism there?
It's all about bradykinin. Angiotensin-converting enzyme, or ACE, is responsible for breaking down bradykinin. If you inhibit the enzyme, bradykinin levels rise. And bradykinin is a potent vasodilator, and it also increases vascular permeability.
So you have a patient who is already primed for vasodilation just because of their daily med list.
And then you hit them with an allergen. You get enhanced vasodilation and potentially enhanced mast-cell activation. It's a dangerous synergistic effect.
And the data supports this, right?
It does. Antihypertensive use in general, but especially these classes, correlates with higher odds of hospital admission and multi-system involvement. These patients just get sicker faster.
So does this mean we should be taking all of our allergic patients off these drugs?
That's the million-dollar question. And the answer is not necessarily.
Right.
They're not absolutely contraindicated, but it requires some really thoughtful, long-term shared decision-making with the patient.
You have to weigh the risk of a more severe reaction against the cardiovascular benefit the patient is getting from the medication.
Exactly. If a patient has severe HFrEF, that ACE inhibitor is keeping them alive. You might accept the increased anaphylaxis risk, but if they're just on it for mild hypertension, maybe it's time to switch them to a calcium channel blocker or something else.
Finally, let's discuss discharge and long-term prevention. The exit strategy is absolutely crucial. We can't just patch them up and send them out into the void.
No patient who has had anaphylaxis leaves the hospital without a prescription for an epinephrine autoinjector. It is their lifeline. It is their fire extinguisher.
And we need to educate them on the carry 2 rule.
Yes, always carry 2, at all times. Why? Because one might fail mechanically, it can happen. Or, much more likely, one dose might not be enough. They might use one, get partial relief, and then their symptoms start to return 15 minutes later while they're waiting for the ambulance to arrive. They need that second dose.
We also have to physically demonstrate proper use. It sounds so simple, stab the thigh, but in a moment of panic, people freeze. Or they hold it upside down and inject their own thumb.
We need to practice with the trainer device with them. Blue to the sky, orange to the thigh. Hold it for 3 seconds. Massage the area for 10 seconds after.
They also need written, personalized action plans and a referral.
A referral to an allergist for trigger identification is standard of care. We need to play detective. We need to figure out what caused this to prevent a recurrence. Was it the shrimp? Was it the ibuprofen they took for a headache? Was it a tick bite 3 weeks ago?
And for some patients, immunotherapy is an option.
Very much so. Venom immunotherapy for insect stings is highly effective. It's essentially curative for most people. And oral immunotherapy is now FDA approved for peanut allergy, which can help desensitize patients so that accidental exposures aren't fatal.
What about patients who absolutely need a medication that they're allergic to? For instance, a cancer patient who needs a specific platinum chemotherapy, or a patient with neurosyphilis who needs penicillin.
In those cases, we have drug desensitization protocols. Under controlled inpatient settings, we can essentially trick the immune system by introducing minute amounts of the drug and slowly ramping up the dose, temporarily tolerizing the mast cells. It's high-wire medicine, but it works.
This has been an incredibly comprehensive review. Let's try to bring it all back together.
I think the chain of survival is clear. It starts with recognition, especially in those treacherous cases where skin findings are absent. Remember, shock without highs is still anaphylaxis until proven otherwise.
Step 2 is immediate intramuscular epinephrine. Do not hesitate. Do not wait for a second opinion. The thigh is the target.
Step 3 is aggressive fluids. You are refilling a leaky bucket. You have to treat the distributive shock with volume.
And finally, appropriate observation. You must respect the biphasic reaction. Keep them safe until the fire is well and truly out.
And if I can, I'd like to leave the listeners with one final provocative thought.
Please, go ahead.
I think we need to reflect on the intersection of modern pharmacology and anaphylaxis. We are treating patients who are increasingly optimized with polypharmacy, ACE inhibitors, beta blockers, biologics. These drugs fundamentally alter the physiologic landscape of shock.
They blunt the body's natural defenses.
Precisely. We are no longer just treating an allergic reaction. We are treating a complex physiological storm in a patient whose compensatory mechanisms might be pharmacologically disabled by the very drugs we gave them for other conditions.
It challenges us as physicians to look beyond the allergy itself to the host's background.
It does. We have to be smarter than the shock.
Thank you for listening.
Until next time.